Hello, everybody. Thanks for joining me today on this little discussion. My name is Ash Panchal. I'm a professor of emergency medicine at The Ohio State University, and also I'm the research and fellowship director for the National Registry. Today, I want to introduce a little bit about the focus group activity that you've actually decided to be part of. And we're really excited for you to come in and be part of this work. And we're focusing our attention on continued competency in EMS. Now, when we think about continued competency, we really think about, how do we train people? And so a lot of times we focus on what is education like? How are we training people? Are we doing team-based training? Are we doing appropriate simulation? And when we think about the word competency, we describe it in a lot of different ways. There's a whole laundry list of things that can describe competency, everything from assessment to ability to knowledge, identifying gaps, all those different pieces. The good part about EMS is that we do have a structured situation to kind of help us getting closer to that area of competency. And so, what does that look like? And the 2019 National EMS Scope of Practice model does a great job of giving us an illustration to talk about this idea. It starts from the very basics, from education. You start to get educated to perform a particular task. And then you get certified as competent, minimally competent, as a part of your training paradigm. And then you can get licensed by the state to actually practice. And finally, to continue and make sure that you continue you keeping those skills that you need, you are credentialed. And that's often done by a medical director who credentials you to continue performing your activities. This paradigm together actually forms the backbone of how we keep people trained and ready to serve the public. But one of the things I think we all struggle with as individuals, but we also struggle with this with the people we train and the people we are sending out there every day to help our community is, are we all really good enough? Do we have the skills to do what we need to do to help our community and really protect the public? And so much of our discussion on competency is around that concept because we see examples. We see examples every single day where we may not be where we need to be or we could get closer. As an idea, I want to give you a vision. I'm going to give you one of an in-hospital setting and another of an out-of-hospital setting so that we can start thinking about and start kind of putting in our head what that good enough could be or where we may fall short. So here's a slight video to help you along that pathway.
Right there, right. That's it? It might be that we may just need to, because you're, pull the stylet. No, no. Yeah, that's fine, ma'am.
Kind of hard to watch. It's hard to watch for a number of different reasons. But one of the key ones is the fact that when we see these images, we start thinking about how we perform. But more than that, we think about the individuals that we're responsible to help support performing. In the in-hospital setting, we expect that we have the best possible care, but things can be challenging at different times and we can have different challenges. And missing an airway in an emergent situation is painful. And it's even harder to watch when you're just sitting there watching it. On the other hand, when we have a cardiac arrest in the out-of-hospital setting, having to watch bystander CPR or healthcare professional CPR, which is what we were witnessing, kind of not make the mark and seeing the pauses and all the delays in the care make it really challenging for us to really say that maybe we're not quite as competent as we think we are, or maybe more so, maybe it's a work in progress. And that's probably more the reality of what competency is. How do we take the progress that we're at and put it all together so we continually progressively improve so that we have continued competency over time. So it starts with one fundamental question. What is competency? When we think about competency itself, competency is defined as an ability to do something successfully and efficiently. It's a very easy definition, but it doesn't really encompass all the tasks, the challenges that we have when we're performing care. But it really is to do this safely to fulfill the patient's needs in our society. And truthfully, when we think about this, the expectation of society is that we are competent all the time. And so the real question is, what level of competency do we want our EMS clinicians to provide care at? And of course, where we start is beginning competency, and we define that as minimally competent. And that's probably where we start. But from there, the question is, where do we go? Now, when we think about how we train people, it's really hard to define the competency level we train our providers at. And part of that depends on the outcome variable we want to achieve and the settings we're in, right? And these outcome variables need to be predefined, they need to be valid, and the training must occur in settings that procedures are conducted in so that we know that people are attaining that appropriate competency level so that everyone's achieving that endpoint that we really want to be at. But that's not always easy. These are ideal concepts that I'm painting for you. And when we think about our situation, this is kind of our large scale concept is when we think about competency education, it starts with our initial education, like we talked about, goes to national certification. And keep in mind, certification is followed by state licensure, two very separate different concepts. And that is then continued with local credentialing and then recertification. Now, the process of recertification is taking that basic minimal competency that we started with and hopefully enhance it such that our clinicians are continually getting better and better so we're always ready to take care of people in the field. And that next state of credentialing or teaching can take a whole bunch of different ways. And we always think about all the different ways we train people, but these are only the starting points. Now, this is a little bit more clear when we think about initial competency standards. So these are clear. The process for defining the levels of proficiency and achievement and the cut scores associated with each of the certification levels are a little more clear because for each level, we're focused on an entry-level competency that is actually defined. Therefore, we have a basis to say this person is a minimally competent candidate at this practice level. And how is that done? Well, through the National Registry's works, they have standard setting committees. And these are ad hoc committees of 7 to 12 members comprised of, you guessed it, EMS clinicians. It is regulators, physicians, educators, supervisors, newly certified providers who are giving us an idea of what minimally competent should look like. It's facilitated by psychometricians, those individuals who are experienced at trying to figure out where these cut points lie, and they focus their career on these standard settings. And that focus after this whole work by this focus group is defining that entry level competency. Now, I tell you all this with the caveat that we do have a contrast. And what that contrast is continued competency. This is less clear. For my agency, I'm the medical director for Delaware County EMS here in Ohio. And for my agency, we have core comps, we have a sim lab, we have continued competency training, we have all these different things, and we have physician checkoffs on every single person who goes through our agency, and that's part of our continued competency paradigm. But that's not the same everywhere. That's not the same for the agency next door to me. And so it's one of the things that we really need to start thinking about is what does continued competency look like? And can we start thinking about what the future could look like? And we did that in a research study. A couple years ago, we derived national continued competency priorities for EMS clinicians. This was the ideal state. We got educators together, experts who are looking at this concept. So who was in our panel? Our panel were EMS managers, educators, medical directors, experts in assessment and simulation. We had people coming over from pediatrics. We had someone from the airline industry. We had people who came in who really understood assessment and simulation to kind of give us guidance of where EMS could go in the ideal situation. And we answered two basic questions. First, what is the content of continued competency in EMS that should be assessed or verified? So that's content. And the second one, what should continued competency of EMS clinicians be like? How should we do this? What is the mechanisms of doing this and how do we demonstrate this? To get to the end point, we did what's called a Delphi process for consensus building. And we conducted this and themes were rated and ranked. So what is a Delphi process? So a Delphi process is a structured communication technique. In this, we process collects expert opinions through structured rounds of questionnaires to reach a consensus. So essentially, what we do is we get a bunch of people together, we ask them a question, get their opinions, and slowly go through there and build consensus on those opinions. This is an iterative process. So we have multiple rounds where the experts continually provide feedback and refine their views with the input. And so that way we improve consensus and get closer to what we as a group may believe is true. And last but not least, who is using this? This is used throughout healthcare, education, policy, technology. And the whole concept here is it supports our experts to be able to anonymously provide that feedback, and it prevents one individual to dominate a conversation. So that way, the smaller voices are able to actually step up and give us a clear content idea of what could be dissension, or more importantly, just the other side of perspective. So when we did this process with continued competency, again, these were the two key questions that we were addressing. What is the content for continued competency in EMS that should be assessed or verified? And how should continued competency be for EMS clinicians be demonstrated? Now, one of the things is when we asked these guys, this panel, we wanted the ideal situation. We wanted, what do you really think? What's the best situation? What's the best type of thing that you could think of that would guarantee competency for EMS? And we followed those rounds. So we did the Delphi process. The first round, we generated ideas. We had our experts generate ideas for both the questions. Then in round two, they rated the importance of all the ideas that everyone generated. And you put a score to that. After that, we cut some of the ideas out, which were low scoring, and then we took the rest and we rank ordered them. So you just move them up or down based on which one you think is the most important. And throughout all these rounds, we talked, we argued, we discussed, and we got to the point that we could generate consensus. Or what do we think is the order for this? And is this something that we can get behind? And so from this experience, we first were able to generate the content areas that we think need to be part of continued competency. And you have a lot of familiarity here, but I'm going to highlight some interesting ones. So you have patient assessment, information processing for critical decision making. You have maintenance of entry-level competencies. You have interpersonal communications. You have maintenance of psychomotor skills. And all overlaid, you have a lot of content knowledge on airway, critical disease, pharmacology, patient care, care of populations, and so on. Now, when we think about the content itself, it's truly important to see these are the ideas that people thought were important. But also, on the flip side, when they talked about the themes for assessment, this was even more interesting. So the themes for assessment and continued competency highlighted a couple of different things. First of all, focusing on evidence-based practice, performance-based rather than time-based. I don't care how long you're sitting there. I want to make sure you're able to do it. We should evaluate both knowledge and skills. We should look at performance improvement over time. So not just that one moment, but over time. Let's follow people out. Frequent and shorter bursts. Test important skills with performance assessments. Incorporate it into everyday life. And involve skills verifications at a local level. So all of these different concepts were things that in the ideal situation, they thought these were very important, could be used. So as a summary, the ideal continued competency from this panel was that it should be assessed, it should be confirmed, it should be performance-based for critical things, and it should be part of our lives. It shouldn't just be something that we do randomly. Now, this was a great experience in the sense that we were able to start thinking about what continued competency looked like and really start talking about new structures that could assure the future of EMS clinicians and assure the care of the public. However, with that being said, there was definitely some gaps which were left completely unaddressed. And let's talk about those. First of all, this was the ideal situation, right? This was if I could do whatever I wanted and I had unlimited funds to make something happen, what would this look like? It's not realistic, right? A lot of times, the things that we're talking about in rural communities couldn't happen, in areas where we're in frontier sections couldn't happen. So we have to be a little more realistic about what we can do. The other thing is it has to be truly accepted. So EMS clinicians, state directors, agency directors, medical directors, everyone has to be accepting of what the idea is. If we put an overburden on one individual, you can imagine the other people aren't going to be interested, right? We have to have a balance. It has to be something which is pragmatic for our population and that everyone can get behind it saying, hey, this is actually going to help care. And that's the last concept. What of these different things are really going to improve competency and patient care? And is that something that we can get behind and say, okay, it's acceptable and it improved patient care so we have the best possible solution such that people will get behind it? And that's why we're talking to you. We want to get together another panel to really start talking about this. So our objectives is to leverage this expert panel to understand EMS continued competency a little further. We want to understand what this looks like in a realistic environment, and we need experts to do that. We're going to use another Delphi method to evaluate these possible structures of continued competency, and we're going to slowly build consensus around acceptability and impact in care. And that's going to be our overall thoughts. We're going to be talking a lot more about this when you arrive, but the one thing I want to set in your mind is you have to be prepared for certain things. First of all, I want you to be prepared to be the expert that you are. You've been invited because your perspective matters, and we want the diverse opinions of the people in the room. Your expertise is actually your experience and who you are and where you've come from. That is the expertise we need, that realistic view of what EMS looks like, right? And your perspective itself is extremely important because it gives us those diverse opinions so that we can slowly find a world of consensus. So what does that mean? That means we really do need you to share your thoughts, right? And sometimes those thoughts are hard to share, and so you can share it in our responses in an anonymous manner, or you can share it in front of the group so that everyone can feedback on those concepts. But this way, all those concepts can be addressed and pulled to light so we can actually talk about them and see if there's better ideas out there that we haven't heard. Now, one of the things I do want to prepare you for is constructive feedback discussions. We will not move forward as a field if we don't constructively criticize the things that we're thinking are right or wrong and actually have a strong, rigorous discussion about these concepts. And so prepare yourself for those constructive discussions so that we know we can move things forward. And part of those constructive discussions lead us to our outcome, which is consensus. So we're going to work toward consensus together. Now, consensus is not a requirement, but it's what our goal is going to be. So with that being said, I'm super excited for all of you to join us. I'm excited for us to take the next step in trying to define continued competency for EMS. And more than that, I'm excited to see you in Columbus so we can continue this conversation. Thank you so much for joining me, and I'll see you in Columbus. Take care.